Good afternoon. Calling to order the Committee on Health and Homelessness. Today is Friday, January 19th, 2024, 1 o'clock p.m. at the State Capitol, Conference Room 309. Members of the Health and Homelessness Committee, welcome to our very first informational briefing. We are jumping right in where we left off at the end of session of May of 2023. We will have members coming in and out, but I would like to welcome, joining us at the table is Chair David Tarnas. Others may be joining us as well, since this is a topic of great importance. Chair Tarnas is the chair of the Judiciary Committee and has great interest in the matters before us as they intersect with homelessness, mental health, and the judiciary. To my left is Vice Chair Jenna Takanouchi. To my right, Representative Bert Kobayashi and Representative Teresa Mato. The topic of today's informational briefing is to get an update on the discussions and plans and next steps of the programs, pilot programs that were being launched at the end of session around behavioral health crisis stabilization centers in the city and county of Honolulu, and a post-booking trial diversion program in the First Circuit Court of the state of Hawaii. These matters, these programs are of great interest to the community, of the legislators on this side of the table, and I know this represents an unprecedented collaboration between the executive branch, the judiciary branch, and the legislature. We have all three government branches of government here, and we have involved the city and county of Honolulu. Waiting in the wings for this project to launch is going to be the other counties to follow and really address the problem of mental health, mental illness, serious mental illness, and homelessness that we see in our communities. We have to succeed. We understand that. And I think what I'd like to do is we're going to focus on these two projects where it's going to be a hard stop of 2 p.m. I've asked Dr. Champion, who is with the Office of the Governor, to provide us the background, the context of why these programs are what they are and why they're important, and what is the vision of the governor, what is the vision of the executive agency.
Good afternoon, Chair. If I could just add, someone who's not present is the public defender, and they have been instrumental in these initiatives going forward, so we just like to recognize their assistance. Thank you.
Thank you, Administrator Miley. Yes, there's actually many folks, and in the course of this briefing and many briefings to come and hearings to come, we're going to make sure we bring all of those stakeholders to the table, because that's why this is going to work. That is why this effort, these projects are going to work. I'd also like to welcome a new member of the Committee on Health and Homelessness, who's also joining us as the chair of the Human Services Committee, Representative Lisa Martin, who is also here to get a really good understanding of what these two pilot programs are, what we're looking at. And so I'm going to turn it over now to Dr. Champion. Go ahead, Dr. Champion.
Thank you. Good afternoon, Chair, Vice Chair, members. It's good to be here and talk about these topics. I'm Michael Champion, Senior Advisor for Mental Health in the Justice System in the Governor's Office. And I'm very pleased that Governor Green has prioritized these issues. They fall, what we will describe today, falls in direct alignment with his priorities on health, solutions for homelessness, houselessness, and mental health, and getting people into treatment, and particularly improving the crisis spectrum and allowing people to get off of the justice pathway into treatment. And so what I'll do today is talk a bit of the background and context, and then some models that our initiatives are based upon. So in the slide that says challenges, the second slide, in this day and age, it's more than likely that a person with serious mental illness will be involved in the justice system during their lifetimes, arrested, incarcerated, etc. And oftentimes that's a reflection of inadequate crisis services to stabilize them in the community. So our jails and prisons have become de facto mental health treatment facilities. And a core bedrock principle is that the justice system was never intended to be a safety net, and that the public mental health system is the appropriate place for care and treatment, and also the private system as well. And applying a criminal justice model to a public health issue is not the answer. Next slide. The wonderful thing about where we are at right now in our times is we have a lot of opportunity. There's a wave going across the country on taking a different approach to public health and public safety for those who are at risk of becoming involved in the criminal justice system. As we see in our state, public safety converted into the Department of Corrections and Rehabilitation. So a core bedrock principle is taking a rehabilitative approach to both public health and public safety, especially when people are at risk of justice involvement. So planning for any new programs or facilities requires a broader system planning or systems change redesign. Next slide. These numbers reflect that serious mental illness, people with serious mental illness are overrepresented in our jails. An incidence of about 4% of serious mental illness in the general population, but in jails is 17%. And if you consider any mental illness, it's much broader than that. And of those 17%, 72% have a co-occurring disorder, substance use disorder, along with a mental health condition. Next slide, please. These are the common diagnoses that we see in individuals who come to our attention. They're the usual substance use disorders, mood disorders, psychotic disorders, but running in red on the side is something extremely important, which is trauma. Trauma is endemic in the folks that we see who come in contact with us, and we need to have trauma-informed approaches to how we engage them and care for them. And as most of you know, we have in Governor Green's office, the first in the nation, Office of Wellness and Resilience, to focus on trauma-informed care principles. And they are working actively with the Department of Corrections and Rehabilitation now to incorporate those principles into their approaches. Next slide. So what are the factors that are driving the crisis that we see? People with behavioral health conditions have a disproportionately higher rate of arrest. When they're arrested, they stay longer in jail than their peers who are not having behavioral health conditions. And when they go out into the community, eventually, they are under a category of having a higher recidivism rate. But what's really important to understand is that in general, they come back to the facility, but oftentimes it's because of violating a condition rather than a new charge. So not taking their medication, not going to an appointment, et cetera. So this is the vicious cycle that occurs. Next slide. The good news is that there's been a lot of time convening to identify that there is a problem and align around that there is a common understanding of the problem. A lot of time aligning around what are the best practices, and we don't need to convene to do that any longer. We just need to convene and organize a coordinated approach with the best practices that we know. Now, why am I saying that? With this slide, the sequential intercept model is a roadmap for building out programs. It's a blueprint for a public mental health system, and it promotes community-based strategies and solutions to folks who get into the justice pathway. And what you see really is something very simple, from 0 on the left to 5 on the right, just a flow through the crisis community context to touch points with law enforcement, in front of a judge, jails and prisons, and reentry back again. Very simple. Next slide, please. I wanted to provide this slide because it gives a list of programs that can be built at each intercept to build off-ramps from justice connection and justice pathway into treatment and continuing to be in the community. And so without going into detail, there's a lot of literature around this that we can share with you at a later time, but I highlighted in yellow 2 approaches and programs that we're going to focus on today. One is a crisis center or crisis hubs that we find in the Intercept 0 and the Intercept 1 landscape. And then the second one is post-booking jail diversion, which you find downstream once you've been arrested, booked, and brought in front of the bench. Next slide. So what we have been seeing, and you've seen it in the newspapers recently, is that hospital emergency departments are full, very, very, very busy. And there's a high volume. A lot of people with behavioral health conditions are circling back and forth, and will be back in the ER many, 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 many times. And the real crucial issue is, was that a productive visit, and was somebody linked successfully to services when they are released? Next slide. So the term deflection and diversion, deflection is a term of deflect away from arrest. Diversion is once you've been arrested. So there's always a question of deflect to what or divert to what? Well, deflect to what? A solution that has become a best practice is a behavioral health crisis center. It's an alternative to an emergency department for people with behavioral health conditions. And in order to deflect out of arrest, it has a culture of treating law enforcement as a quote-unquote preferred customer to support the pre-booking diversion. And essentially preferred customer in the sense that makes it, enhances the likelihood that somebody will be dropped off at a behavioral health crisis center and left there to get treatment rather than brought into jail. Next slide. One example of a behavioral health crisis center that has really took firm root and established is in Arizona. It's been referred to as the Arizona model, and I just want to hit some highlights here of that particular model. It is a facility that has a urgent care or emergency department component, and also has connected to it an inpatient locked stabilization unit. And so the elements of this Arizona model are that law enforcement, EMS, transfers from other emergency departments, mobile crisis teams, or walk-ins can access this facility. The really important principle is no wrong door. They take this approach so that there's no behavioral health exclusionary criteria, and certainly if somebody is in the community and a first responder encounters them, they're bleeding, they're obviously having a medical problem, they'll be straight to a traditional emergency department. But if not, they'll be brought into the Behavioral Health Crisis Center, get assessed, triaged, and treated. This approach allows people who are under involuntary status and walk-in voluntary status. They have a walk-in urgent care in the Arizona model, and you are able to detain a person for an emergency examination or treatment if they're under involuntary status. The services are 24/7, and this is equivalent to an MH1 transport designated receiving facility and an involuntary transport by law enforcement to a point of care for an emergency examination. And in essence, serves as a central receiving facility for law enforcement. Next slide. Now, what are the benefits of having a behavioral health crisis center in addition to emergency departments, or in lieu of, or as an option? You have ready access to person-centered, specialized crisis services, coordination of care, and stabilization in the least restrictive setting. In essence, you do one thing, you do it all the time, you hone your practices and approaches for success. It's an alternative to the emergency department. It pulls down the volume in local emergency departments. It also can become a hub for assessment for possible assisted community treatment, which is required by statute to do that initial assessment when you're having a psychiatric emergency examination. And there are enhanced capabilities to link to community services and supports, including peer supports. Next slide. Now I want to shift to post-booking jail diversion and talk a little bit about the Miami-Dade model, which is the model that our pilot here in Oahu is focused on. So in the fitness to proceed process, when somebody comes into the courtroom and is obviously mentally ill, having a difficult time understanding what's going on, understanding the process due to a mental illness, then there's the option to get a fitness to proceed evaluation. And in our state, that very frequently happens. It also, as a result of that frequency, we have a very large influx into Hawaii State Hospital for fitness-related issues. And so, go to the next slide, please. The really important principle is that a fitness to proceed evaluation and then a resolution of somebody's unfitness to proceed, in other words, treating them so that they become fit, traditionally is very focused on legal restoration, getting somebody to the point where they understand their charges, understand the participants in the court and the court proceedings. It's not traditionally a comprehensive mental health evaluation and a treatment plan to return somebody to the community for success and recovery. Next slide. Busy slide, and I just intend not to look at the details, but to just make the point, you know, when you go into the fitness pathway or competency pathway, it is complex. You get an evaluation, you have to wait for an evaluation, you have to have another hearing and a determination, you may be sent to the hospital or the community, further evaluations, etc. And this applies to minor through major charges. So, next slide, please. We have seen around the country that there's been a flood of individuals into the competency pathway and into the state hospital systems, and with long waiting lists, either in jail or just a backup and doing evaluations in the community. And there has been a growing sense that we need to change this paradigm because it's not working. You can have somebody that spends a long time in a hospital getting their competency restored, fitness restored, costing a lot of money, not focused on recovery in the community, go back to court and may get time served and be released into the community without more. That's not an ideal situation. So the Miami-Dade District Court 25 years ago started a alternative, essentially, to fitness pathway, alternative competency pathways as a way of diversion. And on this slide, I listed the elements of that program. It's an alternative to traditional competency in a fitness pathway. Instead, when somebody comes into the courtroom, and typically one of the parties would say, I'm concerned about fitness, let's get a fitness evaluation, they time out proceedings and they get a comprehensive mental health evaluation focused on what's going on with this individual, what can be put in place to get somebody back into the community for success. They have eligibility based upon their clinical condition, their charges, and their risks and needs. That's assessed by an assessment tool. They develop an they assess and develop a community treatment plan and link to a comprehensive array of community-based treatment, support, and housing, including peers. They're monitored in the community for up to a year with misdemeanor charges when misdemeanor and below. And the legal charges may be dismissed or modified based upon whether somebody's engaging in treatment. And a critical metric is 75 to 80% of folks are houseless when they come into the program. Next slide, please. So at a very high level, this approach, the mental health evaluations that people are getting, are leading to a treatment plan in the community. Next slide. This is a slide that just is a nice diagram of a comprehensive outpatient services. And for somebody to succeed and recover well in the community, you need to consider all these things and assist people from getting all of these supports for true success and stability in the community and not coming back and cycling again. Next slide. This is my last slide. So I want to end on what are the opportunities here in Hawaii. I've been doing this work for a very long time, and I didn't believe in my lifetime that I would actually see us getting to the point where we have real solutions that we can implement to turn the curve around And this slide really demonstrates huge potential for us to work together. So 78% of our jail population is pretrial. So if you do something pretrial and divert, it's going to affect a lot of people. Jails are at average 131% capacity, and 75% of the jail population are incarcerated for Class C felony or a lower defense. So just to sum it up, if you look on the left side, the impact of deflection, and on the right side, post-booking diversion, instead of that saying where we rise the tide for all boats, we want to bring down the tide for all boats. So when you deflect people out of arrest, you lower the people that are going in front of the bench, the courts, and of course OCCC. And you get people, more importantly, engaged in treatment that's going to support their recovery and maximizing their ability to live a fruitful life. With the post-booking jail diversion, what results is a decrease in the number of people going into jail and also the Hawaii State Hospital. And that, in effect, will then enable us to begin developing civil capacity at Hawaii State Hospital and returning the community hospitals to their really kind of core mission, which is stabilization for acute people in the community. We're aligned, governors, CJ, legislative leaders, mayors. We're really going to do this. Thank you.
Thank you. Before turning it over to Department of Health, who has the responsibility of for the first part of implementing the 24-hour crisis centers, can I have my staff or the staff go to slide 8 and post that up? Slide 8, page 8, members, for your hard copies in front of you. I want to put this up in front of you because, again, I want to highlight the two places that we're talking about where we're placing these programs. First, it's the crisis centers, number 3, and it aligns where you see intercept 0 and 1. This intercept model, in fact, reflects community to jails. So, right, we're looking at the place, we're putting a program at the place before, as a person is experiencing crisis, and getting them to treatment there, at a 24-hour/7 place of treatment. The second project that we're going to be talking about is the post-booking jail diversion programs, which is in that intercept 2, intercept 3. A person has been arrested and now is in custody of some form and is a pretrial detainee. And there may be a determination that they are much better suited for mental health treatment or substance abuse. So I'm going to turn it over now. So with that in context in mind, if you could go to the next slide, or slide 11, page 11, members, for you. The Arizona model, as Dr. Champion pointed out, this is the model for the crisis center, the stabilization hub. We've called it multiple things out there in the public: 24-hour crisis center, behavioral health crisis center, stabilization center. This was the pilot project that we had set up in Senate Bill 1594, at which all of the parties, state government stakeholders, were in agreement that we could move forward with this. So providing a little bit of context, even though the bill did not pass, due to the leadership of Dr. Champion and Governor Green and Dr. Fink, progress and conversations continued. So I'd like to turn it over now to Deputy Director Suji to let us know what has happened with identifying a site for our Honolulu Behavioral Health Crisis Center. And I'll turn it over to you. Dr. Champion, if you could share the microphone with me.
Thank you, chairs. Thank you, members of the committee. My name is Marianne Suji. I'm the deputy for behavioral health, but what I would like to do is also introduce some new team members. I think that you all know Amy Curtis. Dr. Curtis stepped down to pursue other things this past year, and while we have not been able to replace her, I don't think that anybody would be able to replace Amy. Dr. Courtney Matsu, who is our medical director, has more than ably stepped into that position. Dr. Matsu is triple boarded and has a wealth of management experience, so we are totally utilizing both her medical degree and her management background. Also, we've been building up our team, and we have created a crisis continuum coordinator, and that would be Dr. Chad Koyanagi. And I think most folks know Dr. Koyanagi for his street medicine. He's out there in the community, so what better person to be able to identify what the needs are for our most significantly in need folks. So I just wanted to say thank you to the city, because this has totally been a partnership with the city and county. Glad to see Anton Krucky here. And he has been able to provide us with the building that we will be having this crisis center. While we would like to think that it's really easy to just stand up a program, it's pretty challenging to get through all the regulations and all the hoops, and we'll talk a little bit more about that. I wanted to really tee it up to Dr. Koyanagi, because he is overseeing this program and can talk a little bit more about who we're going to be serving and how we're going to be doing that.
We have a hard stop of 2 o'clock, so I might be prodding this along and asking Dr. Koyanagi very specific questions. And I want to welcome him to the table, because you're basically going to be overseeing the kind of the clinical work that's going to be going on in this crisis center.
Yes.
Can you can proceed, but if we're going a little bit at length, I'm going to start
I'll be
prodding
very,
you.
very concise. So I'm so happy to be here. So over the course of my career, I've been lucky enough to work at places like OCCC, Halava, Hawaii State Hospital, Queens, Castle. Most important of my work is working in the streets and also at acute care facilities. So we were lucky enough to visit a bunch of the behavioral health crisis centers in Arizona back in December. There are any number of facilities. They do things a little bit differently. Some have adolescents, some don't. Almost all of them have adults. And as Dr. Champion was saying, they all have a no wrong door philosophy. And the benefits from having a place like this is, one, it really decreases the amount of time that police officers have to spend on the streets dealing with our folks. It also declutters some of the ER, and some of the folks who are indigent and Medicaid recipients and homeless tend not to get admitted as often as you would think. Thirdly, they have a bunch of studies that show that patients who are indigent and homeless often have higher satisfaction going to these places, because they're more warmly greeted at the door, and they tend to get more of what they need in terms of housing referrals, case management linkage. So we're at the point of building up this facility on Evil A Road. There's been a lot of bumps along the road, but as Marion was saying, that the city has been extremely helpful at working with us to develop a partnership and allowing us to use the facility for the BHCC, or called the Evil A Resource Center. So the bottom floor is going to be a place for 2359 observation. So less than 24 hours, we'll figure out disposition for these folks. If they need extended observation and care, there's an upstairs mezzanine, which will have about 10 beds, which can help people through their detox, help them further resolve their crisis, working with their community case managers, working with our in-house people. So the site will be staffed 24/7 with psych providers, nurses, peer specialists, case managers, security staff. We'll take really good care of them and refer them to other places if they need to.
I'm going to interject you right now, just so I can ask some very specific questions, so our members know that there's actually progress made. My understanding was in the interim, you folks went through the certificate of need process, and that was approved. Is that correct?
It's still in process.
Okay, why is that still in process, and when can we expect that to be done?
We have some further work regarding some of the construction renovations, and until that's completed, we will not have the licensure for the facility.
Okay, my understanding was that there was a two-point process. You engaged in a certificate of need process, got that approved, but then a second one had to go through. Is that correct?
Yes.
Okay, so you did get it approved initially.
We did get it approved initially, and went through the whole process, and then we were going to go for licensure. So the process is you need to get your CON and that certificate of need, and then go for the OCA license. We were doing that for the second part of the facility, and only in hindsight were we told that we really needed to go through the entire process for all sections of the facility, both the downstairs as well as the second.
Okay, so at the next meeting,
Okay.
what can we do is, what I'd like to do
I
is,
will follow up with you.
what I would like to have is a list of the construction and renovations that the second process has identified, so that we understand and get a timeline of when that can be done. Secondly, I understand, did the Department of Health also identify a contractor who's going to be the service provider in that? And can you provide information on that? Marion, or,
Yes, but we don't have a finalized contract yet.
and who is that contract, who has been identified?
I don't want to say right now since we haven't formally engaged.
Okay. But you have identified a service provider for that?
Yes.
Okay. So right now, we're waiting for the service provider, the certificate of need, and then is there anything else, Doctor, that we need to?
Service provider has been identified, and that will be Care Hawaii.
Okay, and you're contracting with them?
Yes, and that is a contract that's completed. I thought you were talking about who the contractor who was going to do the renovations was.
Okay, so care provider has already been identified?
Yes.
That's wonderful. That's great news. Contractor not determined yet, but that's forthcoming, and you're undergoing
Yes.
contract negotiations with that. Okay, is there anything outstanding to be able to get the facility up and running?
So for now, so keep in mind that the programs in Arizona have been doing this for almost 4 decades. Because of the way we have to have revision of the HRS 334, which allows MH1s to be taken to BHCCs. Currently, they're only allowed to go to psychiatric facilities, which we are not technically one. So that's going to require statute change. And also, so for now, we're going to do a softer opening with acutely suicidal patients who may be MH1s, other folks who may be referred by law enforcement, and referrals from places like Queens and Castle ER through the Hawaii Cares line.
Okay.
And then as we perfect our process and the law has changed, and we can take all patients, adults.
Okay, and I understand there might need to be a MOU executed with the city and county. What is the status of that?
That's a work in progress. So we have some more little bumps on the road that we've come across with some plumbing issues, and so we have to. We're still working on finalizing the MOU.
Okay, can I ask, because we have Anton here, and he's a wonderful partner. Anton, if you can come forward, and I understand so that there might be some continued discussions around the transfer of the facility. What is the city's expectation and position with respect to the being able to execute this MOU? And I know it's under discussions, but highlights what's going on with that MOU.
Well, I think we're really at the sunset level of the negotiations, and we have every expectation that we'll conclude it in a manner that will be in the best interest of all involved, and I'm very optimistic.
Okay. Now, the city isn't going to just turn over the property and turn it all over to the state. What is the relationship going to be from the city as the owner of the building and the state as the tenant?
Yeah, that's an excellent question. We need to turn the control of the building over to the state so they can do the construction that was referenced before. And the construction really is around preparing for the services being delivered. There are particulars to how the room should be. But the city and county still has responsibility for the building as an owner, and so we retain that responsibility to service that for the state.
And I understand that there's still concerns about some of the sewage, but there's sewage concerns throughout all of Kaka'ako and Iwalei. So can you just really highlight, high level, what are the problems with the sewage and that building?
Well, we think we have it under control, but water is water. And sewage is sewage. But we've looked at the city assets and we've cleaned those out. We've looked at the building assets and we've taken care of those. And we're at a state right now where we've cleaned that up and we're looking to see if that finalizes that. But like I said, water is water.
Okay, but you said at the sunset, so
Yep.
you think that maybe in a month's time we can wrap up these?
Yeah,
meetings?
I'm even hopeful for sooner than that. But that particular issue you talked about is cleaned up right now. We're just you have to keep testing it.
Okay, thank you. Members, I know I'm asking a lot of questions, but do you folks have any questions with respect to this particular project, both the physical aspects of it or the aspects of the behavioral health service provider who is going to be operating it? Representative Ganadin, and then I'll turn it over to Representative Martin.
I'll try and be quick. Good afternoon, everybody. Welcome back to the building. Happy New Year. I know we're all happy to be here. How many human beings are we talking about? So as you are
Doctor,
aware, the Department of Public Safety is engaged in a planning project to discuss the development of a new Oahu Community Correctional Center. The Honolulu Police Department is aggressively hiring to work with various communities throughout Honolulu. So how many people are we talking about? I'd like to pin down a number so that we can see how this operates within the universe of public safety.
So on the bottom level, the observation unit will only we'll start out with 8 chairs, and eventually we'll progress to 16 chairs. And on the mezzanine level, we'll have capacity of about 10 patients who can stay up there. And hopefully the length of stay will be about a week. And so we'll eventually refer people on to other community resources after there.
Fair brief follow-up?
No. Representative Martin.
Okay, I can follow up offline as well, but just quickly, I'm very interested in who, would you say you can keep them involuntarily? Who can be kept involuntarily? Is that only people that came in with HPD MH1, or is that people that came in through like the mobile crisis team, ER?
So if we after the or during or after the observation period, if a person requires higher level of care, we'll have to refer them to Adventist or Queens. We also have to have the capacity to do seclusion and restraint for rare occasions where a person requires that level of intervention. And then we will be able to keep people involuntarily. But again, if they require much more support than we provide at the crisis center, we'll have to refer them to the hospital.
So regardless of how they come to you?
Correct.
Thank you. Thank you, Chair.
Okay, one more operational question. So in all of this, we don't have law enforcement here. I've not heard you say that you've had conversations with the system of diversion through Queens, which I understand has the contract, right, that's going to direct potentially. Have you started those conversations?
So we've had police and law enforcement more generally has been a part of our meetings and conversations. We are going to have a formal process for which police via the MHEW process will determine who's appropriate to come to our facility, and then we'll also have ongoing meetings with the police to ensure their officers spend the least amount of time having to wait for us to take their clients from them when they come in.
Okay, thank you. That piece needs to be further fleshed out. And members, I think that, this is the model of what we're going to be doing this year, is a little bit of oversight to ask the individuals before us to keep us apprised and keep coming back to us to provide us with information on the progress of how these 2 pilot programs are unfolding. So at the next informational briefing, I may reach out and welcome Queens to make sure that they're here present and being able to provide to us the kinds of things that they need to hear, policies and procedures they need to start putting into place and think about, so that we can make sure that when the building is ready to go, you guys are in parallel, both working on the physical plant and the operations, so that when we can get our first 2 or 3 people in there, we are ready to go when live go. On that note, I want to switch, because I said we were going to have a hard stop, so now we have 20 minutes exactly for the booking diversion. And if we could turn the slide to 16, members, page 16. That's the post-booking jail diversion in Miami-Dade model. So for this is once a person has been charged. And I'm going to turn it over to the representative from the judiciary to give us what's been happening with the jail diversion program. And we have both a program in the district court, which was Act 26, I believe, and then we had in motion a pilot project that was at the circuit court level, and we kind of want to know what's happening in both of those after Administrator Miley talks. We're going to speak with Prosecutor Steve Alm because his office is directly involved in helping us make sure that we meet the Miami-Dade model with fidelity, and we want to know where we're at with all of that. So, Director Miley.
Okay, thank you, chairs, members of the committees. My name is Rod Miley. I'm the Administrative Director of the courts. I'll be very succinct. Both programs have been initiated, the one in circuit court, the one in district court. We have agreements signed with the prosecutors, the public defenders, and the Department of Health. So we are operational. We are working through some of our operational limitations, and may also express our gratitude on behalf of Chief Justice Rechtenwald. This mental health initiative started as a priority for the National Center for State Courts, the Conference of Chief Justices, and the Conference of State Court Administrators. The state of Hawaii, through Chief Justice Rechtenwald, made this a priority, and the sequential intercept model that you see, these efforts come before people run afoul of the law. And it was really important for us to have the support and the cooperation of the Department of Health. Dr. Champion was with us from the beginning and has become a national leader on these topics. The Department of Health was also instrumental in helping us envision what these centers would look like. Also like to thank Steve and his office, because without their assistance, we wouldn't have a program, as well as the Public Defender's Office, who have been instrumental. So both of these programs are operational, the one in district court, the one in circuit court. Folks are in the program, and we are looking forward to our first graduates from the district court program. And I believe that ceremony is next week.
I'm going to give a high level for the members. So in the district court, it's all nonviolent misdemeanors as approved by the prosecution go through this trial diversion process. In the circuit court, it's the jail diversion program applying to defendants charged with promoting a dangerous drug in the 3rd degree as approved by the prosecutor. And case-by-case basis, the prosecutor and defense counsel could identify to include folks with other charges. Prosecutor Alma, I want to turn it over to you to share with us, a little bit about the pause and what's happening now and how we're going to get back on track.
Okay, well, you have a prosecutor who believes in rehabilitation. So when we heard about this, we were thrilled. So a group of 12 went to Miami. Unfortunately, 6 of the 12 are still actively engaged in this. And I know how, or in the same position. And I know Shirley Noy was a supervisor in probation. She and I started Hope Probation 20 years ago, so we know how important fidelity to the model is. And so when we had a great time in Miami, we were really impressed with it. So coming back, getting it implemented, certain procedures were set up. There were 2 components that were missing, and that was the prosecutors and the public defenders getting a copy of the mental health assessment done by like a doc at the Department of Health before we made the decision whether to let somebody into this. Because the reason we get approval is if they're successful, we'll move to dismiss the case. And as that staff worker got stabbed at Hawaii State Hospital recently, that's the potential for every one of these cases. Serious mental illness is a part of it. So we got to be careful. So the 2 pieces that were missing when this started were us getting an assessment and that a risk assessment tool would be used with everybody coming into this. And I called Judge Leifman, following up, and he said, we treat misdemeanors and petty misdemeanors the same as felonies, and we do the risk assessment tool. Either they try to do it right before admission or right afterwards. And the risk, we need the mental health assessment to decide whether to let the person in. The risk assessment tool is critical to make sure the treatment plan addresses the criminogenic risk factors. Because the Department of Health does a great job, but they kind of focus on the mental health issues. Criminogenic risk factors are other things that lead people to commit crimes, and the risk assessment tool will address those. So when this started in the spring of last year, we'd said, okay, we were tempted just to say we're not going to let anybody in from the beginning because we're not following the rules. We didn't get those two chief components as part of it, but we thought, let's get started, and hopefully we can convince everybody to let's get going with this. Well, I think we let, 7, 8, 9 people into the district court component of this. And I think there was one in circuit court. And in July of last year, we kept bringing it up, nothing was happening. So I wrote an email to all the partners saying, we really want to make this happen. We're working with you. We know at Fidelity, we're trying to do it like Miami. But the two things that were not being done were getting the assessment and getting the risk assessment. So as of that day, we are not going to agree to anybody else coming in to jail diversion, either district or family.
Okay, but my understanding is, and just to kind of break through because I want to make sure we have to meet the 2 o'clock time limit.
Yep.
There has been agreement made that the assessment tool that is going to be used is the one that is being used in Miami-Dade.
Yep.
So we're taking the time to make sure that the training can occur, and then the assessment will go forward. So I don't know, Dr. Matsu, thank you for joining us. I don't know if it's you who's going to speak to the ORAS. Is it the ORAS assessment tool, or is it the courts that can speak to the tool that will be used?
My understanding is that the ORAS is being done by the Intake Services Center,
Okay.
which is not staffed by DOH staff.
And the Intake Services Center is under whose, Kuliana?
Jail, public safety.
Public Safety.
And they had been hoping, I think, ever since last September to get the training, and it's been pushed back several times. So right now it's set for April. And then hopefully they'll get, we're not sure if there's certification with that, and they can get started with that.
And I do believe, I've had conversations with the individual who's doing it at Intake Center, it's Mr. Fri Jan. So maybe at our next meeting of informational briefing of this committee, we'll have Mr. Young come forward and give us an overview of what this tool is. Because I think it sits at the crossroads, right, of mental health treatment and the criminal justice system. And it is a tool that's used in Miami-Dade to help with the mental health assessment and the criminogenic risk. I understand, Prosecutor I know that the judiciary probation has used another tool, but I think, like you said, we want to move forward with Fidelity, so we want the training to happen in April, and then we can start to continue to move forward with this, with Fidelity.
But I should point out that Circuit Court has figured out a way to do it. So they have the Circuit Court probation officers are using the LSIR. So the pause was lifted a few months ago in Circuit Court. So Circuit Court is functioning and they're putting people into the District Court is still at a standstill because that has not happened in District Court. There's no risk assessment tool being administered. So there's a pause still in District Court, not in Circuit Court.
Okay, so I want to make sure that we all understand correctly then. You said in Circuit Court, a tool is being used.
Right, the LSIR is being used, the one the POs are all trained in.
So
and they've been using for 20 years.
We can see some individuals moving through the Circuit Court post-booking jail diversion program tomorrow.
It has already started. It's for people charged with promoting a dangerous drug in the 3rd degree. That's the one charge. And if there's an associated charge, maybe we'll let that in there. But the Miami project and ours in the future is going to focus on District Court because seriously mentally ill people commit disorderly conduct or urinating in public. It's usually that kind of stuff that brings them into the criminal justice system. So the focus of it should be and will be, I'm sure, in District Court on the misdemeanors and petty misdemeanors.
Okay.
And they're the ones who cost the system a fortune in this recycling in and out of it.
Okay, but there is a potential, right? Because PDD3, and I just want to illustrate this for the members, you could be charged with PDD3 if you had a pipe on you and it had just a residue in it, right?
Yep.
So those are the individuals who we want to hopefully maybe get through the program at the circuit court
Right,
level,
but they
correctly?
have to be seriously mentally ill. The vast majority of people arrested for PDD3 are not seriously mentally ill. But that's who we focused on in the Sudafast program in Chinatown, because they all have mental health or substance abuse issues. We're trying to get them help, get them out of jail as soon as possible and into treatment. So the seriously mentally, even in district court, is a challenge because if they just pled guilty, they'd get credit for time served and walk. So it's been very difficult, but I really give them credit, Kainoa and the public defenders, to encourage people into the jail diversion program, because long-term, that's in their best interest.
I don't want to let go of the Sudafast program because that's actually another pilot program, and I want to give kudos to Prosecutor Alm. That is something that he's led, and maybe we can have some briefing information on that at another time. But I want to leave some time for Dr. Matsu to comment on any of the post-booking jail diversion program. And to prosecutor's point of view, Dr. Matsu has in fact replaced Dr. Curtis. So even though Dr. Curtis is the signatory on the MOU, it's really, she was representing the Department of Health. And so Dr. Matsu, you now carry this opportunity to really help the people of our communities. Did you want to comment on what AMHD's role is in this post-booking jail diversion program?
Sure. I just want to make clear that it's the program is ongoing. So even though there have been challenges with the district court due to the assessment that they want to provide according to the Miami-Dade model, it has been progressing on the circuit court side using a different type of assessment. And so since the start of the, when people came back from Miami, my understanding is since about April until now, there have been about a total of 675 people who've actually gone through the screening to be determined whether or not they're eligible or not eligible for this program. There's a significant number of folks who are, for whatever reason, had been unable to be interviewed due to whether or not they had been aggressive at the time that the person was there to be interviewed, safety issues in the cell block or staff shortages. There's another large component, about 38%, that actually refused to go through any kind of assessment. But then there's that other block of folks, about 25%, who actually had been assessed formally. And of that, there is a small, very small amount that were found to be eligible. So, I think looking at it, there is a large volume of screens that do come through. We are challenged by resources. I think that's the thing that we should all pay attention to, whether whoever does the ORAS on the district court side, even for the jail diversion side, we want to make sure that we have the positions and the positions filled so that we can continue this program. There are successes, even though it's a small number right now since this program is in its infancy. We have folks who, like they said, are graduating and who have really been engaged in the program, gotten into treatment, and hopefully, we see reduced rates of recidivism at the long-term outcomes for this. But yes, thank you for your support, and we'll continue to work closely with the various folks who've been involved with this program since the beginning.
We have 6 minutes, members, before our hard stop, and I just want to see, are there any questions about the post-booking jail diversion? And again, we'll have more time, but are there any specific questions? Representative Garcia, and then Yashi.
Thank you, Chair, and thanks for being here today. It's good to hear that there are about 9 graduates soon. That's good. However, I just want you folks to know that the sentiment I hear from some residents is that this seems to be like a soft on-crime approach. And so my question is, what strategies are in place to address potential challenges such as community perceptions of leniency? And how will you ensure that the criminal justice system maintains public trust throughout the implementation of this model?
I think from my perspective, it's really, as a clinician, we're coming in looking at folks who really have mental illness or substance use, and I consider that also an illness. And we're wanting to provide interventions at that point, and then treating that And then if somebody's treated, then you can look at the other side and whether or not they need the judicial and the criminal type of involvement.
And I think part of it's education, because thousands of people come into district court, and the probation officers there have huge caseloads, and so they're not going to get that kind of help, even if they're placed on, most people aren't placed on probation, but if they're placed on probation, if you have a few hundred people, there's no way you can provide services. So if they come into court and plead guilty, they get credit for time served and they walk out without any supervision. In this program, they get a lot of supervision. There's a lot of programming that Department of Health. And on that subject, they're going to need a lot of money, because in Miami-Dade, they have 34 people working for the court. They have a 1% tax on every restaurant in Miami that grosses $400,000 or more, not the hotels. So they have this steady stream of money coming in to help it. In Hawaii, the Department of Health is the one providing all these services. So they really are going to need help as this grows, because we expect this to be a real big player, but it's going to take money.
And it'll take a lot of partnership, I think, because we can't do it all by ourselves.
Yes, if I could, Representative, 2 parts that I would note. As Steve was pointing out, the assessment is really important, and that's the primary way to assure the public that the individual is not putting the community at risk while undergoing this process. And I think the other part is that in order to participate, at the end of the assessment and evaluation process, a treatment plan is developed. So the clinical aspects of what is causing that kind of behavior will be identified and addressed through services. So the goal is, at the end of the period, whatever was responsible for those behaviors will be addressed, and the behaviors reduced or eliminated, ideally.
And even the fact that there aren't more screening is, for district court, there's really been no point in doing any screening since July, because nobody was going to get let in, because there was no risk assessment tool. So they talk to a lot of people. Kainoa is great. They really try to engage. But for the district court part, that has been on hold since July.
Representative Kobayashi, 10-second question.
You answered it. You need the money. How much and when?
DOH needs more money.
We need people to want to do it.
Hold
We
that
have
thought.
some big
Representative Martin?
I just wonder, as this program grows, the actual treatment services, whether it's long-term detox for drug treatment or whatever, are we going to find that we don't have enough of those beds and those spots once we actually divert people to nowhere?
That's a great question. That's another part. When you're asking about funding, we do need more supportive housing placements. We need more substance abuse treatment beds. If there could be some flexibility for some funding for ancillary items. So, it's very individualistic. Folks who come in might need things like their ID replacement, hygiene, small things like that. So just some flexibility in the funding.
Okay, we have a lot of things and threads that we need to continue to follow up on. Members, these kinds of issues will come up in the bills before us, but I think this interaction of having us being publicly informed about the progress and where we're at is going to be a positive way of moving forward, holding all of our feet to the fire. Because we certainly are going to be fighting for funding. In the House Majority Package is funding for operations for a behavioral health crisis center. So you already have the commitment, at least from the House, and I know the Senate is going to be there too, to make sure that these kinds of programs are going to be standing up. And I think it is at such a crisis point, as Representative Garcia said, right, as we all recognize in all of our communities, when we notice people and see people decompensating on the streets in front of us, they are committing crimes, nonviolent, petty misdemeanors, mostly harming themselves. And so we really need to take action, and this is the year we're going to take action. I want to thank everyone for being here. We are going to continue this conversation. I encourage members, please talk to these individuals across the table from us, and we will see you next week as we begin our hearings. We are adjourned.